everybody. Welcome to the Dental Handoff. Today I have back with me one of my new favorite people, Liisa Moore from the wonderful area of Canada. Liisa, welcome back.
Thank you so much for having me back. It is truly the Great White North this time of year.
How much snow is on the ground?
A lot. And it's bitterly cold. It was minus 26 when I got up this morning, Celsius. So yeah, I think with the wind, it felt like minus 34 or something like that. It's chilly, but.
Okay. When does it start getting warm and the things start to melt?
Usually around March. Usually I feel like that kind of turns the corner. February can be hit and miss here. We've had some really nice kind of mild Februarys and we've had some cold ones too. But usually in March, we've kind of turned that corner and the sun stays out a little bit longer. And yeah, it starts to turn that corner of the bitterly cold is kind of coming to an end.
Well, I know that like in Virginia, it's like 3 inches is a lot of snow. So what's a lot for you?
Yeah, way more than 3 inches. Like 3 inches, like that's like people are grabbing their skis and going to the hill and we get that, sometimes we'll get up to like, again, being in Canada, we'll get like 30 centimeters in like one dumping, 25, 30 centimeters. Wow. And then, yeah, my kids were off on Wednesday. They had a snow day because we got a little bit of a dumping, but cool. The kids love it. They just get to sleep in, right? Us adults still have to brave the weather.
And we had to figure it all out of like how we're going to deal with the interruptions all day. Yeah. I mean, in a loving way, right? But we're entertaining. We're not only working, we're doing all the things that we do to navigate.
Yeah.
Thanks for coming back on today. You guys, last time, I don't know if you heard the first episode with Liisa, but we started to riff in different areas. And I was like, you've got to come back on because she's so knowledgeable. She teaches at the college up there and also for RDHU. And just, a wealth of knowledge that you have. So what we thought that we would talk about today, because I know that Liisa loves this topic and so do I, is about orthodontics and the adult patient and why it's not just about straight teeth, right? Liisa, what is it about?
So ortho is definitely my passion. I got into ortho right out of hygiene school and I've never looked back. And I feel like now more and more adults are getting treatment. I work full-time clinically in an ortho office. All we do is ortho. And what I see a lot of now are once the kids are done, then it's mom's turn, right? Because the mom or dad, they see the improvement in their kids and it's becoming something that's way more affordable. A lot of patients, they'll have benefits now, right? Through work or other insurances. And, the aesthetics of it, with things like aligners and, the clear bracket systems, things like that, they're becoming more aesthetically pleasing. So a lot more adults are jumping on and it's funny how they start their treatment because they say, I've always had, a diastema, space or crowding, so they start off with an aesthetic kind of goal in mind.
Right.
And it's wild how that transforms throughout their journey, how they'll come in for their, 6-8 week appointments and it's not about aesthetics anymore. It's wow, my teeth feel better. They fit better. I can chew better. I don't get food stuck here anymore.
Yeah.
It's all those things that even though it might start off as something cosmetic, it opens their eyes to so much more.
Totally. And, I think that, we learn a lot about ortho. We know how to look at growth patterns in children and know that spacing is good. And if there's not spacing by a certain age, it's probably not as ideal. And then you talk to doctor about referrals to an orthodontist. But there are so many times where I think that we call straight teeth with adults healthy. And the impacts that teeth that look straight can be having on each other because it's increasing trauma throughout the mouth. You're getting cracking, chipping, receding, all of those things. So ortho is not just helping with the social six, it's helping functionally throughout a lifetime to put a person more in a protective bite. Mm-hmm. So Liisa, when you recognize this, not that it's not just for kids, where did your mind go with it? Like, what did you think? Like, oh my gosh, where's the spid my entire life? Like I did.
I think for me, it was kind of an easy transition for me because I had my ortho as well. I guess technically I was an adult when I had my ortho. I never had ortho as a kid. I did have crowded teeth, but I mean, again, I was 21 when I had my ortho. So if you can count that as an adult, I don't know, but and
Yeah, it is. I mean, yeah,
it's
yeah,
as far as your chart goes, you're an adult patient.
that's right.
And I remember when I got them, I was working in ortho, and the doctor I was working for was very generous. And yeah, he's like, "You've never had ortho?" I said, "No." He's like, "Do you want them?" And I got it. He didn't charge me. It was a perk of working there. And when I got them, I went home. My mom's like, "Why did you get braces? Like, there was nothing wrong with your teeth." And I was like, well, and I was like, of course there was. I had crowding, and like flossing here was hard. So I went through my treatment, and then when I got them off, I remember showing my mom like the before and after, and it's just kind of like, whoa, like it's almost like you don't realize how good your teeth can be until I just think so many adults have that mentality like, oh, it's not, my teeth aren't that bad. My teeth aren't that bad. I've lived with them for 40 years, 50 years, 60 years. Like they've done me well. And then they don't realize how good they can be until after the treatment and after they've done it. And
Right.
yeah, I think there's still a lot of stigma now with adults. I feel like I had a great conversation with my students actually that the like my parents' generation, right? I feel like the boomers, I feel are kind of the last generation to have that fear of the dentist. I
Yeah.
feel like everybody like my age and younger, I never, they were going to the dentist when they weren't wearing gloves and they were in chairs like this probably, right? And these barbarians. So they have this image in their head of ortho as they remember the kids that had the headgear and like bands on every tooth. And now they come in with their kids or their grandkids even, and they look and go, that's it? Like it's just that little thing on your tooth that's not this big contraption. And I feel like that kind of gets it going and sparks it for them to be like, well, maybe it is something that I could do.
Yeah, for sure. And the clinical signs that we're seeing that we used to explain away, like recession, we know is largely contributed to the teeth in misalignment
Mhm.
and the teeth with crowding. You want to talk to the audience a little bit about that? I mean, I can talk about this for hours, and I know that you have love, so I don't want to. I mean, just like the crowd, you guys, we're just like it's just a little bit of crowding, but let's talk about what the little bit of crowding leads to.
Yeah. And I mean, not only the recession, again, too, like flossing, trying to keep those areas clean. The people, they go to their dentist and they go every 3 months for cleanings because the calculus just builds up in there so quickly because they just can't access it.
Right.
And I feel like a lot of them are surprised now when they go and see their dentist and, they complain about things like that or like the recession or even like chipping and wear. And they go, well, yeah, I'd be happy to fix that for you, but you have to go get ortho first because I can put all the bonding on those edges that you want to make them nice and aesthetic again. But with that traumatic occlusion, they're just going to keep breaking.
Yeah.
So it's the clinical signs that, like you said, it's more than just straight teeth, right? Even though they're straight, it's that when you're in a traumatic occlusion, that's the only way to fix it would be to get some kind of ortho.
That's right. And when you think of it, it's because I know that in the United States, like we don't get that much instruction about we learn about what class 1, class 2, class 3 is. And it's just like, what is it on the right? What is it on the left? Right.
Mhm.
Like those types of things. But what does that really mean? And how does that impact the patient over their lifespan?
Mhm.
And with the crowding, like to Lisa's point, of course, there's the biofilm removal and it's trapping more. It's not a self-cleansing, but then also as well, if the teeth are raveled in, thinking about the trauma that those certain teeth are taking more so than the others. So like when I'm scanning with iTero, I can see the pressure points that those teeth are withstanding and where the pressure is heavier and where it's hitting on other areas that to me it's kind of like a little red flag of going, hey, these are high risk areas. Because if you think about it, that's what we're doing in hygiene. We are caring for people based on their risk factors. So to me, when I do a scan, I pull up the occlusogram. And for those of you guys know what I'm talking about, it's the red. It's like a heat map. But for those of you all who don't know, it's a function of the iTero. It's specific to the iTero, and it's a button that you push. And after you scan it, it's one scan that takes about 3 minutes after you get practice. And it shows you where the teeth come together and all those pressure points. And if teeth are, the teeth are supposed to come together, right? But if it's more so than what it should be. So if I see that it's more so than what it should be, I'm like, this is a risk factor. And then so we as hygienists are making recommendations based on that, right, Lisa?
Yep. iTero, like I said, I love iTero is such a great tool because it's not, I steal this from Carrie Lipacek. I'm sure she won't mind that I use her reference all the time, but it's not Carrie telling, it's Carrie showing, right? So when you have that patient in your chair and they say, no, like I don't clench, I don't grind, I don't, I'm like, are you sure? And then to bring that up. And like you said, it's like a heat map and it's such a cool technology. And I feel like every time you, even as you're scanning, in our office, we scan it. Of course, we scan everybody. We're in ortho, but I just laugh because the kids, their head tends to always go towards the screen because they want to see what's going on, and even the adults too, and they're looking and they don't know what you're doing. And then you show them after, and like, it's just such a unique tool and an amazing tool to have right at your fingertips, right at your chair side. And like I said, it takes 3 minutes. And then it's such a great discussion point that you can actually, instead of giving the patient the mirror and showing them in their own mouth and they're trying to see, it's all on the big screen for them. It's such a wonderful, wonderful tool.
Yeah. Because when we look at, I don't know about you guys, Lisa, when you look at the recession that is in patients' mouths, we were taught that it was from what? Toothbrush abrasion. And that's not the case. But I mean, in some cases, like if they're brushing with like a really hard toothbrush, you can see some of the lines, but it's not going to be unique to one tooth. Like a lot of times when we're looking at things, we're going to see it's isolated to things, but it's mostly from abfraction and misalignment. Is that what I know that's what you educate about as well.
Mm-hmm. Yeah, we see a lot of it. Yeah. And it's, again, too, it's usually an adult, people that have had the same bite for years and they didn't realize it was traumatic. And same thing. And what is kind of a thing too, is they go, and a lot of hygienists too, you're the dentist. Oh, you're just brushing too hard. You're just brushing too hard.
I know.
Right. And it's just such a misconception for a lot of people, but and I mean, and when it becomes aesthetic too, when they're in the smile line, and I feel that's when they come and see us, is when it becomes an aesthetic issue. And then, you can kind of educate them on, well, look at, again, too, you pull up that beautiful iTero scan and you're like, well, yeah, look at these hard areas where you're contacting. And then it's kind of like, wow, like you just see that light bulb go off on their head sometimes. It's, yeah.
Yeah. But even if you guys, even if you don't have an iTero, even if you have a digital camera, hopefully you're using it with every single patient to take the images, because it's hard for patients to realize what 1 millimeter means. They don't know the significance like we do. I mean, 1 millimeter is a lot to us. And they're just like, well, it's just 1 millimeter. It's fine. It's like 1 pound on the scale. You can take it off, you can put it back on, or 5 more, or 5 off. Some of it's easier than others. But with that, it's a lot of change. And so iTero helps you pick up on that. But even if you have a digital camera and you can show them where the receding is, you can talk about, because you're also, I bet you, if you see the receding, you're going to see the wearing, you're going to see some fracture lines. You're going to see those other attributes of the tooth that show the stress and the trauma that tooth is taking. So if we know that risk factor based on certain things like clefting, chipping, cracking, receding, then we know the history of it. Like if we had a magic 8-ball, which I do, hold on. You were to say, I know, I just found it the other day. I have my magic 8-ball. If I were to look at this, if it were to grow up, what would it be? It would be like, okay, it would be a crown, right? We don't need this. We know clinically what happens to that tooth if it keeps taking the same trauma. So for me, I think, to me, if I was the patient in that chair, I would want to know that it was there, that it was starting.
No, absolutely. And it's, yeah, like I said, it's all about educating them, right? And I mean, we have seen them too, and we'll see a lot of, say, adults come through and they kind of go, oh, it's the same kind of idea. They'll book a new patient exam because their dentist sent them, right? They pay the fee and they're like, I'm here because my dentist told me to come. And then they kind of like, oh, whatever, no, it's not for me. It's only 1 millimeter, no big deal,
Yeah.
But then it's so funny that you see them come back like 2-3 years later, and now it's not just 1 millimeter anymore, right? And they're like, kind of like, maybe you were onto something. Maybe I should have done this 2 and 3 years ago. So, I mean, there are those ones too that it takes a little bit for them to process. And again, too, that 1 millimeter doesn't trigger them in any way. But then once, they go back to their dentist for their 6-8 month recall, and they're like, you might want to go back.
Yeah. I think another thing that motivates patients is pain, sensitivity. of course. It's this tooth right here is really, it's cold sensitive. Have you noticed that the gum line is further up than what it used to be? Yeah, actually I have. And matter of fact, I pack food there too.
Yeah.
And so that's the way that the conversation starts. And then we are in the great position to talk about what happens if that continues. Just like our doctors, like our physicians talk to us, okay, you can be managing this, but here's what happens if you don't ever do anything about it. And you can be fine like this for years, but all of a sudden it's going to become a problem. And it doesn't always hurt right away, but the effects are still there.
Yeah, that's just it. And I feel like that it is just having them come in is a great talking point, because I always tell this to my students too. Their chief concern or chief complaint is very rarely going to be the same as yours. Right? They'll come in with complaining about, like I said, their diastema or their crowding. And then that's your opportunity as the clinician to point out those other things, right? Like the recession, like the calculus buildup in those tight, crowded spaces. It's the same thing when people go to a general office. They haven't been to the dentist in 20 years and their main concern is whitening, right? It's the same in ortho. We have to take those opportunities to educate them on, it's more than just, it's so much, ortho is so much more than just pretty teeth, like straight aligned teeth.
Yeah. And people don't realize that if you're catching it in the stages earlier, or to put the bite back into alignment, that it becomes more of a protective bite because you have the guidance of the teeth that's supposed to be there, like a textbook, almost as close as you can get it. So different teeth aren't taking the forces as much as other teeth are. And so it's distributed differently. Mm-hmm. Then while the investment is, yes, it's clear aligners of whatever brand that you're liking, or it's ortho, if it's just brackets, if that's what's indicated, it is saving you money to do the ortho, because what's going to end up happening to those teeth? Cracking, chipping, crowns, endo, extraction, implants. We know where our magic 8 ball takes us, right? Yeah. So people talk about the cost and it's like, but wait, let's talk about this.
Mm-hmm. Oh yeah. Cost is a huge thing. Orthodontics isn't cheap. Yeah. Right. And it depends on the office, and it depends on a lot of people having insurance and coverage and things like that. And a lot of offices, I feel most offices do some sort of a payment plan kind of thing. But it's, and that's where you need to see you need to help see that patient see the value in their investment, because it is an investment. But again, too, what's one implant or 2 implants cost, right? And even just your time too, right? Like those are a lot of appointments to go back and get implants or like you said, crowns, root canals, all the other therapies that could go along with it, grafting, to get a graft. It's expensive and it adds up too. So it's one of those things to see the value in that investment.
Yeah. And then, thinking too, Liisa, about the receding and it being gradual over time. And as I'm talking to patients, I'm also looking at other risk factors, periodontal risk factor, because receding, it's not soft tissue. It's hard tissue that you're losing. It's bone support that you're losing. And so it's actually causing bone loss, and you cannot grow that back. You cannot grow it back. And so it's putting them at a higher risk factor there. And then also it's exposing their roots. So we have to be figuring out, are they at a higher caries risk? What's their buffering capacity? Do I need to do nutritional counseling? What does that look like? And so this is such a lead in to go on their chief complaint, like to your point where you were saying, it may just be that they think that it's extra spacing right here or whatever that is, but really take that opportunity to then turn that into, okay, because what that's telling you is that they're talking about a space, I keep pointing to the wrong side, spacing, that they care about the way their mouth looks. They're saying this matters to me and my appearance of my teeth.
Yeah. And I feel like the other, like just to go on when you said the spacing thing, I laugh because in my career, I've been doing this. It's my 20th year this year as a hygienist. So I started in 2006. So I'm officially 20 years in. And I started in ortho right when I graduated. And there was 3 cases that I can think of. One was younger. She was 20 something. And the other 2 were adult women. And they went through with full ortho treatment, but they wanted to keep their diastema. They had a central diastema
Oh,
and they
wow.
wanted to keep it. So this one woman, she was in her 60s, I believe. She was in her 60s. And she needed to get some treatment done because in her lower. And so she was like, okay, and of course, sometimes you can just treat one arch, right? But in her case, we needed both arches to adjust her bite. And she said that, and she was originally, she said, no, I don't want to do it then. And we're kind of like, why? And she goes, because I don't want to close my space. She goes, that's who I am. I've had it 64 years, and she wanted to keep it. So he worked it into the treatment plan. He was like, yeah, we'll keep it. And same thing with another woman too. And she's like, it's who I am. It's part of me. I've always had it and I want to keep it. So those are the ones that they saw the benefits of it otherwise. So they weren't
Yeah.
doing it for aesthetic reasons. And they were, so I mean, if that's a concern too, and it's just something that, again, it opens that dialogue and that discussion to be like, if it's something that you want and the doctor can do it, they just work it into your treatment plan. It's customized treatment. It's not everybody gets everything. Everybody gets all the spaces closed and, all this. If
Right.
that's something that you want to keep, it's individualized care. Right.
Right. That's a really good point.
Mm-hmm. Yeah.
I mean, even think about how dentists, doctors, orthodontists work in, like if someone has an implant up front, it's really no different. They have to work around that. They have to customize it based on what the patient has. And if they have to keep space for something else that's there. So if you're thinking about this, if you're looking at your smile going, I don't know, I kind of always like that, or I didn't think I was a candidate for that because I have an implant on my front tooth.
Mm-hmm.
Talk to your doctor about it. It's just something for you to consider about that. But also, one of the things I want to talk about, Liisa, too, is how we are biasing our recommendations. How we are biasing our recommendations for the patient who's older, for the patient who we think doesn't have money, but not interested, has 4 kids. We have no idea what someone's situation is, right? It's up to us to tell them what they have and to talk about the consequences and how it can help them, right? Otherwise, how do they know and how do they make decisions?
Yeah, exactly. It's all about education. And again, too, you can't assume anything. You can't assume that the 25-year-old woman is going to want clear aligners. I mean, it's an assumption that we all kind of make when they come into the office. It's like, she's not going to want metal braces, and it's kind of one of those things. It's like, you can't make that assumption. Maybe they do. Maybe they're not aligner wearers. Maybe they're not, it's so to make the assumption too, that people will know more than they do, and I feel like that's an assumption too, that a lot of us as healthcare workers make too, right? You kind of jump the gun and you see that you're talking to another adult. So you think they might know things already. And it's like, they might not necessarily know. Like the example, they think their recession is because they're brushing too hard. They think they get calculus build up quicker than everybody else because their dad did and their grandfather did. So it's genetic. So that's why I get it all the time. Right. I mean, not that doesn't play a factor, but it's just, they have predispositions too. And we have to be there to clarify and to educate is the main thing.
For sure. I mean, think about how many of your patients have said to you, no one's ever showed me how to floss before or how to brush my teeth like that, using like the circular bass method. No one's ever told me that I need to brush my gum line. It's the same thing. We because we're basing our care on a set of assumptions that unless we're talking to the patient and we kind of back up a little bit and question those assumptions for ourselves and them, then we understand where their knowledge base is and where to pick up.
Mm-hmm. Yeah, I think the biggest gap and I hear it every week, maybe not every day, but I hear it every week, is I'm too old for ortho.
Oh yeah.
I hear that so many times and it's like, I'm too old for ortho. And I was like, no, like you're not too, like, I think the oldest we had, she was the sweetest lady too. She was in her 80s. So she had to get a lower tooth extracted and then she had a bridge and it didn't fit anymore. So she had to get a couple of aligners just to line things up. And it's like, there you go. She was in her 80s. It's like, you're not too old for ortho. I mean, you need to get clearance and there are processes and steps to make sure you're a candidate, but an 80-year-old is no less a candidate than a potential, 35-year-old, right?
That's correct. That's correct. And I find too that it goes along with, like we were talking about, the importance of the smile and overall health to a patient. Overall health, the health of their mouth, you can kind of connect this triangle. with them to understand them, especially if you've seen them for a little while. And you can take that factor out of it is that, I'm too old for this. It's okay. Well, do you like the way your teeth look?
Mhm.
Okay. What we know now is it's not all about how the teeth look. What we've noticed from your scan and what we've noticed from the digital images that we've taken is that your gums are receding. And what we know about that, it's not really gum disease. It's periodontal disease, because we're losing that bone support. So in educating them that way, they start to think of it differently and are able to make it more informed choices, because they could say, no one's ever told me that to you. No one, because we didn't know that. And that is a perfectly fair thing for them to say to us, that, you know what, nobody's ever told me I had gum disease before. That patient who has wings of calculus, but it's like, I just had my teeth cleaned 6 months ago and no one told me I had gum disease or 7 molar pockets. And you're going, oh, help me.
Yeah. Absolutely. It's so much more than just aesthetics. It's a hygienist kind of called overall health, right? Oral health is overall health, and ortho is no different. It's not just aesthetics. And I feel like now, with more and more adults coming through and realizing that, and it's one of those things, so many times they're like, I couldn't afford it when my parents couldn't afford it when I was a kid, so I'm doing it now. And it's really, really growing the adult patient. And I mean, even to have them in your chair, if just for the hygienist in the GP practice, you might see these adults come in and all of a sudden they come back 6 months later and they have attachments on and clear aligners or brackets. And I mean, I would hope that they would maybe be in that corresponding way with them, but you never know, right? And it's just kind of to have them in the chair and just be like, oh, it's an opportunity for them to educate, like, oh, I'm really glad you did that, and re-encourage them, and positive enforcement to be like, way to go, doing something for you and made the investment, and this is great. Your teeth are looking great, and what an improvement. And yeah.
I think for all of us in the dental field, I guess I'm making an assumption, Lisa. I think people in ortho I'm just like, you're in ortho, you look so good. I always think like when people are in aligners, when you're in aligners, just look like you're talking like this for a little minute, for a minute. I'm sure it's the same with traditional orthodontic braces, but it feels awkward at first. But to compliment them and say, you look so good. I mean, and mean it, right? But to tell them that we see that they're making the choices for themselves, that vote for themselves, for their overall health, that they look to us for that encouragement.
Yeah. I had a patient, he finished his aligners and he's like, well, now that I'm done, it's my wife's turn. And he laughs. He's like, I'm officially that person that looks at people's teeth now. So he's like, we'll be at a restaurant. And he's like, I'm looking at their teeth. He's like, I'm that person now. And it's funny. He just appreciates it so much more now that, he's been through it and did it. And he was one of the ones again too that realized it's not just aesthetics. And he did aligners and he's like, this was so much easier than I thought it was going to be. He was like, it was virtually painless and it was, quick, and appointments were over like 10 to 12 weeks. It's not like it was a big commitment. I mean, it is a big commitment, but just he was blown away. And and he's going to be he's not even in the dental field, but now he's probably going to be one of the biggest advocates for it, because this was great. He loved every minute of it. And now he's like, I can chew, I can floss, I can, it's just game changing. And that's a rewarding part of our jobs, right? Seeing the happy patient afterwards, right?
It is. I remember when I was in my last trays for Invisalign, I had it for I have 8 and 9 were class 2 mobile, and I had divergent root. I have divergent roots like this, so I have a lingual retainer now. But so people would look at me and say, you have a perfectly healthy smile, but my recession was just progressing. And I was like, it's not health. What's the definition of health? It's stabilized over time, and it was changing. But I remember in my last sets, I said to my orthodontist, I said, I feel like this is my whoopee. I don't want to take my appliances out. I feel like I'm comfortable with them now, and because they're a part of you for that length of time. And I was like, okay, can I just wear some? I just feel better if I wore some. It just felt so weird to not be with them.
Yeah. Oh, I know. And we do get, even with full braces, we do get those, everybody thinks that kids are always so excited to get them off. I mean, for the most part, they are. But you do get the odd one that they're like, it's part of me. I love them. I've had them for, 18 months, and they've just, and especially as a kid, 18 months is a lot different than an adult, right? It feels like forever when you're 14 years old, but it's to have them. And then, I mean, they're always happy when they come off. They love the result and it feels great. But some of them are kind of sad to let them go because it's become a part of them.
Yes, it was such a surprising feeling to me. I didn't expect, but I guess the point of all this, you guys, is think of we're encouraging you, right, Liisa, to think of things differently, to look at health in a different way, to look for the signs of it. Use your intraoral camera, whatever device it is that you have. If you have an iTero, use the occlusogram function. If you don't know how to use it, you can reach out to Liisa or I, or you probably have an iTero rep there in your office. I know that a lot of times we say, I don't have the time to do that, but truly using that function makes your communication a lot more succinct, and it ends up taking less time than if you were trying to explain it like with this weird graph that is not even the patient's mouth. It just makes better sense when you can explain it in that way.
Yeah. And again, the takeaway I'm hoping that, everybody takes from this is that, yes, I know we are crunched for time in our hygiene appointments. It goes by really that hour, 45 minute, however long you have for a recare exam. It goes quickly. But I like to, just because you have that adult patient in your chair, never make the assumption that that's not something that they're interested in. There's no harm in asking to be like, have you ever thought of orthodontics? Have you ever thought, and what's a referral? I mean, if they accept, great. If they don't, fine, make a note and move, document it and move on. But it's orthodontics isn't just for kids, and it's not just aesthetic.
That's right. And it's always worth talking about, and it's always worth planting the seed. It's just like when I remember when I graduated, Liisa, when I was talking about a crown that a patient I really thought it was whatever they had, it was going to end up being a crown, large amalgam at that time, whatever it was, that I felt in a way like I was selling them on it. And it wasn't. It was just talking about the next stage of whatever was going to happen with their condition. And I would like for us to just think about it like that we're educating, because I think that's what drew so many of us where we are and who we are today, is because we want to educate, we want to connect with our patients. And so if you kind of reset and think, what is that patient truly there for? They trust you. Just think about how you can work this into their conversations, and, try to keep our bias out of it and just tell them what we're seeing and let them make their decisions.
Mm-hmm. Yeah, I love how you said that. Yeah, don't look at it as selling. We're not selling. We're not salespeople. I mean, some of us are salespeople, I guess, if that's the role you have. But look at it as more of an educator. You're not selling, you're educating.
That's right. I mean, the person who's educating on that pair of shoes that you're looking at on the counter isn't necessarily selling them. You're just asking questions and they're answering, right? It just is. But Liisa, thank you so much for the conversation today.
Thank you so much. It goes by so fast every time. It's just, I feel like we just hopped on and here we are. It's crazy how fast the time goes. And
I know, I had to get you on for a different topic.
Yeah, easy to talk about something you're passionate about, right? With great company.
It really is. But thank you for your time, because I know that you're super busy. So thank you.
Thank you. I appreciate it. That's always a pleasure.
Yes, my friend. You too. For those of you all know, I always ask, what's my favor? I ask Liisa to go on to the Dental Handoff and give us a 5-star rating on the Apple Podcast, because Apple Podcast is the one that matters. If you're watching this on YouTube, please go on over and like the like button right now. Just go ahead and do it. Make a little comment to say, oh, we love you, Liisa. We love you, Liisa. You're so pretty, or this is so helpful, whatever. The algorithms care about your comments. So please do that right now if you don't mind. And then if you really like the Dental Handoff, go ahead and subscribe so the algorithm recommends it to friends that you love and care about. But thank you for all of you and for what you've been doing in the lives of our patients. And we will see you again next week, my friends. Be well. Thanks again, Liisa.
No problem. Bye. Take care.
Bye-bye, everybody.